Today's Learning in Action Network event is focused on objective key results 1, which is depression. We have 3 networks today. We are shortening the time frame to be 30 minutes, and so I'm going to get started now and keep the NCC introduction comments short before we hear from the networks. So again, starting today, these will be shortened to 30 minutes. We do have a post-event survey, so please give us your feedback in there if you like the condensed format, if you prefer the 60-minute, or if it more depends on your schedule, please fill out that post-event survey. Other than that, the call is being recorded. Everyone is muted upon entry, and that we will post this on the NCC website and the YouTube site following this presentation the next 3 to 5 business days. So the purpose of a Learning in Action Network is to share approaches. Please use chat. To do so, identify how we can use the information we hear today at your facility or in your organization, and then try to take one idea from today's presentation to implement at your facility. And please commit to sharing these learnings and ideas. Have a conversation with your colleagues. We're just going to do one opening polling question here. It is around the change packages. And so that QR code will take you directly to the change packages for the NCC site if you haven't seen those before. If you have, can you please put in chat, have you previously used the NCC change packages? Just click that to everyone. That's how we're communicating today. And let's just see if chat's working. Put your answers in there. Okay, I don't see any answers yet, but please do try to use chat. Hopefully it is set up correctly and everyone can use it today. There we go. Yay. Thank you, Jamie. Thank you, Yolanda. Just lets me know chat is working. And again, if you need the link, it is that QR code, which I'll share again at the end. And without further ado, we are going to present 13 and 15 together, and then we'll back off and do an ESRD Network 14. So I will pass this over to Justin.
Hey, thanks so much, Sarah. So my name is Justin Carr, and I am the Patient Service Manager for ESRD Network 15. I also had help with Network 13's Patient Service Manager, Lucille Fernandez, who's on PTO right now, so I'll be presenting for us both, okay? So really quick, Network 15 represents the states of Arizona, Colorado, New Mexico, Nevada, Utah, and Wyoming. Got a whole bunch in there. Network 13 represents Louisiana, Oklahoma, and Arkansas. So we'll be kind of incorporating feedback and information from both of those areas in today's presentation. So thanks so much for being here. Okay, Sarah, could you advance slide? Thanks. So today we're going to be talking about some of the work we've done on the depression project so far, engaging in the treatment of patients identified as having signs of depression. So I'm going to present kind of my information first. Thanks so much, Sarah. We're going to be discussing the goal really quickly, discussing some of the barriers that we have historically heard about and that we've heard about in this project up to date, and then how we're trying to address those barriers. Okay, so I'll keep going. Thanks, Sarah. Next slide. Great. So really quick, just the goal here. Per the statement of work, the network shall increase the percentage of patients receiving or having received treatment by a mental health professional after having been screened positively for depression as identified in the QIP attestation over the task order period of performance. That's a lot of verbiage, but basically it means increased patients getting treated for depression, right? The data for this comes from EQRS based on Medicare claims. So just kind of a foundational level, that's what we're talking about, what the goal is, and where the data is coming from. Okay, next slide, please. So the barriers on this, we've known about some of the barriers impacting patients getting treated for depression for some time. We have queried both, Lucille and I both, our coverage areas and then the facilities in the project right now to kind of drill down on this. What we found over time is that the barriers really fall into basically 3 buckets, okay? There are patient engagement barriers, which you might know of, a refusal to engage in mental health, a refusal to follow up on a referral, or just some cultural, I'll say, understandings or some cultural apprehension towards mental health or cultural reluctance. Provider barriers can be a lack of providers, providers not having a lot of availability to schedule appointments. Some providers, depending on which sort of provider specialty we're talking about, might be uncomfortable with diagnosing patients. And both 13 and 15, we have a lot of rural areas, and so really just not having enough providers to go around can be a real issue we've seen. Insurance barriers. So that could be the insurance provider not being accepted. Often Medicare sometimes might not be accepted, particularly in some of the rural areas. That can be a real issue. Or maybe the patients don't have insurance. There can also be authorization issues, and we've gotten feedback from facilities. They're experiencing all of these things. I would like to highlight some of the patient barriers. I think that can be interesting. So some of the patients, they just they don't believe that they might actually feel better or happier. They just can't get their heads around that. Some of them have, as I mentioned, kind of some sort of mental health, either cultural stigma or just a mental health stigma within their own kind of hearts, if you will. Some patients just don't believe they're depressed. And then sometimes there are even issues with technology. So in some areas where we've tried to roll out telehealth as a way to address some of the issues with providers in rural areas, technology can be an issue for some of those folks. And then, of course, there can just be appointment overwhelm, particularly for dialysis patients, right, who already have a 3-time-a-week standing appointment. Next slide, please. So I like to go through with you really quick kind of our approach here. The first thing we did was do an assessment. As I mentioned, we came into this having some previous assessments under our belt with work on this. We've done now some more. We're about 2/3 of the way through our first PDSA cycle. So we've queried these facilities, these target facilities, a couple of times. So what we did is we chose kind of, just so you know, at the start of this work, we chose 10 kind of low-hanging fruit facilities in both of our networks. What I mean by that is they reported in the data we had as having high incidences of patients screening for depression, but the reporting lacked details regarding a follow-up plan. So we did kind of a pre-assessment at the start of the PDSA cycle, and we literally just last week completed another assessment. So in addition to revealing some of those local barriers, which we just talked about in the last slide, it was interesting as we're interpreting the barriers in the reporting, there seems to really be some staff burnout showcased in what we're getting back, right? We get responses, and these are direct quotes. Patients do not want services, or very difficult to get appointments at local mental health center. And what responses like this seem to indicate to us is that the providers have tried, the dialysis staff have tried to work with these patients, and they're just hitting a lot of barriers, and there's kind of some burnout on working on this. As we did our one-to-one calls and really started engaging with these facilities, it was, at least in my experience, I can certainly attest, kind of a constant reminder, just talking to the social worker. They really feel like they're banging their heads against a wall trying to get some movement with these patients regarding mental health. And this qualitative data really also has some issues, I think, underneath it with some of the quantitative data. And what I mean by that is the batch cycles where we're getting this data from an EQRS. It can be delayed to a degree. When a social worker puts in and does the assessment in January, we might not get that information for a couple weeks, a couple months. And we got that in reporting from facilities when they would go follow up with the patients we identified with them. Here's another direct quote: a high score is from the previous year and not as relevant for some of the patients. And that highlights something we found consistently, that they would go to follow up with a patient, and maybe it was just situational depression, and now they feel fine. Or again, it can be hard to get accurate reporting from the patients. I think we all know that. So maybe they've altered their responses. Who knows? But the fact is, some of the data we're getting in and of itself might not be the most current, might not be the most I'll say valid, reliable, say what you will, but we got to start somewhere. So next slide, please. So taking all of that into account, we decided we needed an intervention that kind of re-engaged both patients and staff, kind of gave them a fresh point of discussion, a fresh frame of reference. It needs to be flexible enough to support various paths to treatment. And, you know, again, part of this is we need to allow for patient agency in their choice of providers. And we also, of course, need to not be pushing unnecessary diagnoses. But ultimately, we want something, of course, that supports the goal of this project of getting patients treated. So let's talk about what we developed. Next slide, please. Okay. So what we did is we created a fax template. and both our networks did this. It's based on an idea we received from an LDO, though we tweaked it quite a bit. It provides some pertinent information for any mental health provider. A primary care doctor could benefit from some of this information, and of course a more specialized mental health provider. We hope that it helps to re-engage the patient in discussing mental health through kind of a symptom-focused framework. So some patients we got reporting just kind of knee-jerk response, didn't want to talk about mental health, but they might want to talk about why they're feeling sad or tired or feeling a little snippy. Um, so we took all this feedback that we got from the facilities in our discussions and in our surveys, and we incorporated that um, and incorporated in a way that hopefully makes the facility staff feel heard. To hopefully inspire them to re-engage. But we also, again, hopefully this is flexible enough to be applicable to most mental health referrals. And just really quick, hopefully you can see it, but um, it's basically something that they can send to the provider, talking about the recent mental health discussions. It gives them kind of a point of reference for the assessment tool that they've used, and then it gives them some codes. Um, and the codes hopefully allow for the doctor or the provider just to know generally what buckets maybe the work they're doing with that patient could fall in. So we sent this out to our Behavioral Health Coalition and to facilities in the project, and then of course queried them for feedback. And so far the feedback's been great. Responders reflected on the quote unquote directness of the tool. They appreciated the attachment of the billing codes, and they stated things like, it's a good handout to keep conversation going, that depression is treatable. And what all of this is telling us is that the resource is kind of hitting the targeted objectives for the intervention. So we're happy about that. Next slide, please. So from here, where we're looking to kind of go is to continue follow-up with our targeted facilities. We'll be winding down the PDSA cycle with them, but still looking to support them in their work. And of course, continuing with the next cycle of facilities. We'll be collecting data on the usefulness of the resource and then ultimately monitoring the data reports we're getting to see if this is having any sort of an impact. And of course, that's our hope, right? So let's go to the next slide. What I'd like to talk about from Network 13 and what Lucille wanted to focus on was some kind of direct examples of the work here, the resource, and then how this is impacting not just the project, but stretching outward to a lot of the work we do at the network with cases and with helping actual facilities in their work with patients. So next slide, please. So we're going to look at some of the feedback she got really quick, going to discuss some of the case successes she'd had, and then look at some of the future implications really, really quick. Okay, next slide. So some of the feedback she got, and it mirrors some of mine, is that the clinic staff reported to her that a lot of them that they felt they needed some additional training, which again, that template is given in context with some discussion on how to utilize that as a discussion point and how to utilize that as a in the context of overall trying to help the patient with their mental health. Mental health stigma was big for her, just as it was for me. And one interesting piece that came up in her area was about the need for Spanish translations, the need for making the information more accessible to folks. And we'll talk about that a little bit more. Next slide. One case she had, at one direct target facility, she gave a social worker in Louisiana the resource. She was able to turn it around and refer the 10 patients that she was working with to their respective primary cares for assessment and treatment. And sure enough, they're in various stages of getting evaluated with their primary care, which is as close to a best case scenario as I think we could hope for with this tool and with our goals for this project. So we're really happy about that. It shows that at least not just in theory, but in practice, it is possible that this is going to do exactly what we want. So we were happy to see that. Next slide. But in addition, this has rippled out into some of her other work, and ours too, we're seeing this. A Louisiana clinic called to discuss some options about a patient that just has refused mental health treatment. This was not a targeted facility. And there were some barriers there and some concerns about if this patient might be discharged possibly. So she was able to provide the resource. She had that handy, the template, give some technical assistance similar to what we've given to our targeted facilities, though of course a bit pared down, provide them some guidance on next steps to refer treatment, and it helped as of now, I can tell you, it's really helped kind of avoid an IVD there, which we thought is great. So that leads us to next slide. Beyond just the work in this project, we're seeing some increased clinical outreach is possible by using the tools we're developing and the approaches we're developing here. It's will help to avoid some IBDs. Possibly, we're hoping to reduce some stigma and provide some technical assistance. Next slide, please. For both of us, really, as we look not just in the project, but beyond it, to what we're gaining already from doing this work. We're looking forward to using this as an opportunity to focus on some health equity. As Lucille found with the need for some additional translations of mental health, we're really looking to fold in some resources and approaches for obviously non-English speaking primary cultures, because of course, I think all of us work with folks like that. And then also to refresh and have some positivity to interject on these discussions with clinics, because it can be such a heavy lift to get patients to engage in their mental health. And we all know this, and we are seeing some progress from this. Of course, it's not a miracle. It's not going to fix everyone, but anything that can help us move the needle, I think, is really useful, and we're just encouraged by what we've seen so far. So last slide. Here's our contact info if you want to reach out to either of us. I sure do appreciate your time and you being on this call, and that's all I've got. Thank you so much for your attention. Sarah, anything else I can do for you right now?
No, that was excellent, Justin. Thank you for that. Love seeing emerging practice already with some data points behind it. If you do have questions for Justin on his networks presentation, please pop those into chat. And while you collect your thoughts, we are going to move forward with ESRD Network 14, and Mary is going to introduce the speaker for that network.
Well, good afternoon to everybody, and I know some on the West Coast, good morning. So I'm Mary Albin, the Executive Director for Networks 8 and 14 with Alliant Health Solutions, and we are pleased to have a speaker from our DaVita West Arlington facility. And funny story is, I actually opened that facility when I was with DaVita and got it certified. And it's a beautiful clinic in a really nice area. And we're just pleased to have Mariana Alvarado present for us on a case that she has. So Mariana?
Thank you for introducing me, Mary. So my name is Mariana. I'm a social worker at West Arlington, and I will be going over a case that I've had that kind of piggies back off of what Justin kind of went over. So if you could go ahead and do the next slide. So I'm just going to keep mine kind of short and simple and just go straight into my case example to kind of put all the pieces together and kind of go into what this kind of can look like, a good success story. So I had a Spanish-speaking client who scored positive on the depression screening, was having symptoms of like little interest, feeling down, having trouble sleeping, and a lot of basically scored positive on the depression screening. And I had been working with her for several months. I was building rapport with her, personalizing care of, kind of engaging with the client. And she had expressed times where she was having difficulty with accepting care and assistance from her children. Working with Spanish-speaking and sometimes Hispanic communities, we have to kind of think of concepts like Marianismo, which is essentially a term that describes like women self-sacrificing for the benefit of the family. So these are things that I am aware of as I'm working with some of my Spanish-speaking clients that are women that have taken care of their families. And knowing some of these things, I've kind of been able to use that to address stigma sometimes with just mental health treatment. What are some of the symptoms that you're experiencing, and addressing those, and educating them, providing psychoeducation on depression and anxiety, and so I've had kind of done some of those things. And there was a particular day where everything kind of just meshed together. She had scored positive on the depression screening. I use the distress thermometer to engage and find out what are some of the stressors, what are the things that are going on, why are you distressed? She explained that to me, and so we addressed it with the doctor, and she essentially was able to get, she was open to treatment and was able to get medication, and several months passed and she essentially came off the medication. It was more kind of situational, but that's kind of what my case was with her. So she is doing a lot better now, and is building that relationship with her children to get that help, and just overall doing really good. So that is my case example that I wanted to present to you guys today.
Excellent. Thank you, Mariana. So we do have some time. Usually we do not open all lines to this call, but we do use chat. So now would be a great time to pop any questions or comments in the chat box for our speakers today. I will pause then and ask everyone for polling question number 2. If there was anything that you heard in these presentations that you could implement in the next 60 days. The QR code there does take you again to the ESRD National Coordinating Center's change packages. If you haven't seen those yet, we refresh those every year. So there will be a new one out for 2023 later this year. Quiet group today. I don't see any questions in chat for our speakers. So I will conclude here then to say that we will have a post-event survey. Here is a QR code to those change packages. If you haven't seen it already, please find and follow us on social media. We're on all of those channels. This presentation will be posted to the YouTube site, the ESRD NCC YouTube site, about next week. So if you would like to share this with a colleague, you can share it there. And then again, just an ask for everyone to complete that post-call survey. Particularly, we added a question about this abbreviated format to 30 minutes, if you prefer this, or if you prefer the longer session. So please do give us your feedback. Thank you to everyone today. I hope everyone has a great day, and until we see you again, take care.